Hello, everybody. My name is Caterina Marchio. I am a molecular pathologist working at Candido Cancer Institute in Italy. And for today, I'm going to present a case that I would define simple, yet is going to be full of very useful features that we can discuss together from a diagnostic point of view. And the case is focused on the detection of NTRK gene fusions. Here, you can have a look at my disclosure, and then we can dive into the case. So this is a case of a male patient, 50 years old, that for some symptom got to clinicians that performed some radiological investigation, and a nodular lesion in the lung was detected. At the same time, with the CT scan, they also detected the fact that the patient was at an advanced stage because there was also a brain lesion. A first attempt of a lung biopsy was performed, but unfortunately, the pathologists only were able to observe some rare atypical elements, but a proper diagnosis could not be performed. At the same time, the patient had to undergo neurosurgery for the brain lesion. And on that lesion, the pathology report was describing a poorly differentiated carcinoma that was showing some sarcomatoid features. So here we have let's say two features that are a bit not in contrast, but it's a kind of poorly differentiated lesion that is also showing, together with epithelial elements, some sarcomatoid flavor. And the origin of this tumor was supposed to be actually the lung, based on some immunohistochemistry that was staining positive for TTF1 marker. Based on that, the patient started radiotherapy on the surgery bed and also on the other lesions that were detected. So when the oncologist had the pathology report, based on the fact that there was a possibility of having a carcinoma, even with some adenocarcinoma features in the lung, at an advanced stage, he ordered actually the whole profile that you would order for a lung adenocarcinoma at an advanced stage. So the molecular profiling, including mutation for analysis of mutation for EGFR, KRAS, BRAF, HER2, and also the whole set of gene fusion that could be of interest, ALK fusion, ROS1, RET fusion, and also NTRK gene fusions. So the reason why I'm stressing that is because based on the analysis and on a chat between the oncologist and pathologist, it was actually acknowledged that, let's say, a kind of origin from an adenocarcinoma could be actually described. On the left-hand side, you have a field of this tumor that is clearly forming some kind of glandular features. And then in the middle and on the right-hand side, you have other two fields in which this tumor is actually getting less differentiated, so it's going away from the adenocarcinoma features. And on the right-hand side, you really see the atypical elements that were recognized to be as sarcomatoid elements. So possibility of an adenocarcinoma with poor differentiation, we go with the whole set of investigation. So given that we are focusing on NTRK gene fusion, I will just recap a little bit for you what would be the workup in case you want to let's say, screen for NTRK gene fusion. In the NTRK gene fusion positive tumor scenario, you have actually two possibilities. We know that there are some histologies, and these are just a handful of histologies: secretory breast cancer, secretory carcinoma, salivary gland, congenital fibrosarcoma, and congenital mesoblastic nephroma that harbor a specific NTRK3 gene fusion. So in that case, if you have to start your workup, you would wonder whether you fall into one of those lesions. And if that is the case, actually, with kind of this algorithm, you would just go for a technique that is able to detect that specific gene fusion. But, and this could be even just a fish analysis. But in the field of, let's say, screening in a type of agnostic fashion, given that NTRK gene fusion can be detected in any tumor type, actually, you need to also set up your lab in a way that you can be able to investigate NTRK gene fusion in a wider field. So if you are not in that scenario, and we are not actually in that scenario of those specific histologies, then if you want to screen for NTRK gene fusion, you need to know whether you have the possibility to do sequencing at your lab. Because in that case, the easiest thing would be to adopt sequencing. exploiting a sequencing platform that will be available at your institution. And you just need to double check whether the panel that you're using is including the possibility to detect NTRK gene fusion, NTRK 1, 2, and 3. And then preferably you would adopt an RNA-based panel, but you can also approach it from a DNA-based standpoint. And then you can screen for NTRK gene fusion together with other genetic alterations. Once you find the gene fusion, we may discuss whether it's needed and it's useful to also perform immunohistochemistry to confirm the expression of the chimeric protein. Just to finish up the scenario of the screening, if you do not have the possibility at your institution to perform sequencing, including also the investigation of NTRK gene fusion, then you can use immunohistochemistry as a screening tool. And then all of the cases that would express any type of expression, even minimal, that you detect in your slides, need to be reflexed by sequencing. So actually, in our specific case, we were exactly in the scenario that we were screening for let's say, a tumor that could harbor an NTRK gene fusion, but at very low levels. So you would be really in this area that you need to screen for other alteration together with NTRK gene fusion. And actually, at their institution, they perform an NGS analysis with a targeted panel of 50 genes. The panel includes a DNA-based and an RNA-based workflow. And the RNA workflow actually includes the investigation of, as you can see from the list, NTRK 1, 2, and 3 gene fusion together with the standard gene fusion that are actually screened for lung adenocarcinoma typically, and also for other kind of, let's say, agnostic approaches, including also the investigation, for instance, of fusion-affected FGFR 1, 2, and 3 genes. Based on this investigation, actually a TP53 NTRK 1 fusion was identified, and together with the result of the NGS, the pathologist that was in charge of the case also performed immunohistochemistry with a pan-Trk assay. And here, I think you don't need to be a pathologist to understand that this brownish, very strong staining pertaining actually to the tumor cell is actually a proof that you have the chimeric fusion. The chimeric fusion is actually overexpressed in the tumor cells. So based on the results, the patient is about to start treatment with TKI with entrectinib. Why did I actually choose to present this case? Well, this was a kind of case that I define paradigmatic because it was a story of success. And I think that it represents how the patient should be screened in order to be able to reach a specific treatment, and also a specific treatment that is based on the detection of a very rare alteration. And I think that the success of this story is based on the fact that there was a teamwork, that the strategy that was used to screen also for rare alteration was really good, and the method that the lab used was appropriate to detect all the possible alteration for which we have, let's say, an option, a therapeutic option for the patient. So actually, I'm presenting this case on behalf of the two clinicians that managed the patient and also the material. So the whole credit of the detection of this rare alteration goes to Fabrizio Dapo and through Luisella Righi, respectively the medical oncology in charge of the patient care. And Fabrizio has a solid background on molecular oncology and has specifically, let's say, trained on lung cancer, as well as Luisella, who is a molecular pathologist that is working in a hub center where they perform a lot of tests for lung cancer, for the profiling of lung carcinoma. And there was also, as you can see from the little map that I'm showing here, a collaboration between institutions. And this gives also the chance to say that when you have the possibility to detect rare alteration and to treat patients with rare alteration, sharing the material with the right lab at the right moment is actually key. Now, if we have to discuss other key points in the, let's say, diagnostic workup in the pursuit of rare alteration. Lung cancer is also a good example because we do not have just NTRK gene fusion, but NTRK gene fusion are part of this wide list of molecular alteration for which we know that we need an answer because we have a related compound. So the material, the managing of the material is also crucial because sometimes we work with a small amount of material and we need to to get all of the answer to this question. Most of these alterations can be screened with a molecular method, but you need also to say some slides for some detection of the expression of proteins such as PD-L1. And for gene fusion, you may decide also to have immunohistochemistry to complement your molecular analysis. Another comment that I think is spot on, actually, especially related to the fact that you may use or not immunohistochemistry for the detection of gene fusion, either in the screening set or in the, let's say, in the scenario whether you want to confirm the overexpression of the chimeric protein, is actually the fact that in this specific case, the pathologist also, on the top of identifying the rare gene fusion, decided to perform immunohistochemistry. And I think right now, NGS is the method of choice to detect this type of alteration, but having immunohistochemistry following NGS can be reassuring for the pathologist. And also, given that these are rare alteration, I would bet any pathologist that finds such a rare alteration to confirm this alteration with immunohistochemistry. Then one of the final point is the fact that this alteration was actually detected in a patient that had a tumor that was otherwise wild type for other gene alterations. So actually, NTRK was the only option. So when we devised this kind of algorithm for screening for NTRK gene fusion, we were wondering, it was 2019, we were wondering who were the patients that should have been tested. And we already, let's say, drafted the fact that actually any malignancy at an advanced stage should be screened, and in particular, those for which we do not have any other actionable alterations. So those that have been proven wild type for other relevant genetic actionable alteration. And this is actually now become our practice. But the fact that you should, let's say, think a little bit more about let's say, tumors that are wild type for other driver genes is something that has been described in the literature. So if you look at some papers, you would find that NTRK gene fusions are enriched in specific scenarios, in particular in those tumors that have been proven to be wild type for key driver genes. And also within the set of colorectal cancer, NTRK gene fusion are enriched in MSI high colorectal carcinomas, and this is specific actually for colorectal cancer. So based on this data, actually, you have a kind of hint when you have to insist to stress more the screening for NTRK gene fusion. And we also performed recently a study in which, let's say, the topic was really when I should go further with gene fusion testing in general, not just related to NTRK gene fusion, but including NTRK gene fusion. So we provided some real world data. So based on a screening that is performed molecularly speaking on melanomas, lung adenocarcinomas, and other tumors, in which clinically speaking, you would just test some genes, not a huge amount of genes, like 10, 15, and you would find your patient to have a tumor that is wild type for those key alterations. That is the specific scenario in which you are encouraged to stress the screening for gene fusion, because you would find an enrichment for NTRK gene fusion. And we demonstrated this also for lung adenocarcinomas. There was a significant enrichment of detection of gene fusion in those non-small cell lung cancer that were proven to be wild type for EGFR mutation, ALK fusion, and so on and so forth. So I'm going back now to the case. Let's go back to histology, because the final comment that I would like to make is about the tumor type. So the report was actually stating that there was a poor differentiated carcinoma with some adenocarcinoma elements, but also sarcomatoid features. And we already commented the fact that there was a kind of triphasic neoplasia. And actually, when Luisella, who was the pathologist in charge of this case, reviewed the case, also commented on the fact that this was a combined neoplasia. So an adenocarcinoma with also some neuroendocrine features and some sarcomatoid features. And this tumor type is actually called and labeled blastoma according to the WHO classification. And so this gives me, let's say, a final remark on the fact that NTRK gene fusion are actually agnostic. So regardless of the fact that this could have been an adenocarcinoma of the lung, this tumor should have been screened for NTRK gene fusion because regardless of the adenocarcinoma or the sarcomatoid features, it was a tumor that possibly could have harbored and was actually harboring a relevant NTRK gene fusion. And with that, I would like to thank you for your attention, and we will have time to discuss live in Paris.